Welcome to everyone who's joining this webinar on what are co-occurring disorders. We'll be getting started in 2 minutes, so thank you so much for joining. Again, we'll be getting started in 2 minutes at noon Eastern Time. Thanks so much for joining us. Again, welcome everyone who's joining us for the webinar today. This is just a quick note that we'll be getting started in 1 minute with our webinar on what are co-occurring disorders. So glad so many of you have joined us today. Thank you so much, and we'll be getting started in 1 minute. Hello everyone, my name is Ben Odell and I'm with the Center for Faith and Opportunity Initiatives at the U.S. Department of Health and Human Services, or what we like to call the Partnership Center. We are delighted that you've joined us today for the first in our new webinar series on mental illness. Our first webinar focuses on co-occurring disorders of mental illness and substance use disorder with a specific focus on opioid use disorder. I'll more fully introduce our speakers in a moment, but first, a few housekeeping notes before we begin. This is an educational webinar, which is off the record and not intended for press purposes. If you are a member of the press, we'll be happy to connect you with our press office here at HHS after the program. If you're having difficulty hearing us clearly, you may find it helpful to use the call-in number that's available through the system rather than listening through your computer or whatever your device you're participating with us today. You may experience better sound quality if that's the fact. In case the fact. Also, please note that this is our first webinar on the Zoom platform, so any challenges you experience, let us know. We'll make sure through the chat feature that we do our best to address any challenges that you might have, and bear with us as we adjust to this new platform for our office. But we're so glad it's allowing us to connect with even more people throughout the country. We'll be sending a link of the recording of today's webinar along with our other resources in our follow-up email, so look for that email in the next day or two. And if you have any questions, always feel free to reach out to us at the email address partnerships, that's partnerships with an S, at H as in health, H as in human, S as in service.gov. And finally, we do have a full program today. We hope to get to some questions at the end, and we're eager to share those questions, either to answer as many as we can or share them with our presenters today who are experts on this issue. But right now, let's go ahead and use that Q&A feature. At the bottom of your email, you can click the Q&A feature and type in where you're joining us from today. What city and state are you joining us from? Go ahead and type that into the, as you would type a question. Let us know where you're coming from. Minnesota, Florida, New York, Pennsylvania. Oh goodness, they're all coming in here. This is wonderful. Ohio, California, North Carolina. So many, it's take Iowa, Colorado. This is wonderful. It's so great to see so many parts of the country represented, so many leaders from around the country who are interested in learning more about mental illness, learning more about what we can do and better addressing co-occurring disorders specifically. So before we turn to our presenter, I'm excited to welcome our director, Shannon Royce, to the webinar for her to share with you a little bit more about this webinar series we're launching today. Shannon, let me turn it over to you.
Thank you, Ben. I appreciate your leadership in preparing us for this webinar and the series that we're starting. My name is Shannon Royce, and as Ben mentioned, I serve as the director for the Center for Faith and Opportunity Initiatives here at Health and Human Services. And I'm so glad you've joined us today from all over the country as we launch this important webinar series to increase awareness about mental illness. We call it Mental Illness 101, and the purpose of these webinars is really threefold. First, we're helping faith and community-based partners, groups, and their leaders understand commonly diagnosed mental illnesses. We want that understanding to then help those leaders recognize the signs and the symptoms prevalent in adults, adolescents, and even children. And finally, once those signs and symptoms are recognized, we want those faith and community leaders to have the awareness they need to guide individuals toward recommended levels of care to meet the needs of those conditions. Through increased awareness, mental health myths are dispelled and individuals, families, and ultimately our communities can thrive. We're starting today, as Ben mentioned, with co-occurring disorders. As we build on our previous work on the opioid crisis over the last 2 years. Our hope is that leaders like you can understand when someone struggling with a substance use disorder might also be struggling with a mental health challenge as well. So as we focus on co-occurring disorders today, know that we'll be hosting a webinar a month for the coming months. And our next webinar on May 9th is going to be on anxiety disorders, another very significant challenge faced by many individuals around our country. And that will be led by Dr. Tim Sizemore, and we really look forward to your joining us for that as well. Now let me turn it back to Ben and have him introduce our speaker. David, thank you for joining us today. We look forward to hearing from you.
Thanks so much, Shannon, for being with us today, for welcoming everybody to the webinar series. And now we get to turn to someone who's become a great partner of our center here, Dr. David Jenkins. Dr. Jenkins is professor of counseling and the director of the Master's in Addiction Counseling program at the Department of Counselor Education and Family Studies at Liberty University. He has served as clinical director for the International Board of Christian Counselors of the American Association of Christian Counselors, and is on the executive board of the Society for Christian Psychology. Along with these titles, Dr. Jenkins is someone with whom the center has had the privilege to present and connect over a number of meetings, helping faith and community leaders better understand how they can address the opioid crisis in their local communities. And so we know you are in for a treat today with this presentation. So without further delay, let me turn the presentation over to Dr. Jenkins to share with us a little bit more about the research and the background and some of the key things to know about co-occurring disorders for faith and community leaders. Dr. Jenkins?
Thank you, Ben. Welcome, everyone. So glad for this opportunity. I want to thank the Partnership Center and Shannon and Ben and their staff. They're doing some excellent work and really appreciate them. Also want to thank Liberty University, my organization. They have been behind this project and have been very helpful in getting things set up. Most of all, I want to thank you for being here in attendance. I appreciate the interest and motivation that is demonstrated by your presence here. So let's get started. I want to start with looking at some numbers first. What are we looking at numbers-wise? What's kind of the scope of what we're looking at when we're talking mental disorders and co-occurring disorders? Also want to then look at some of the disorders specifically and how to recognize them, but also how that may link up with opioid use disorder. Then also want to look at some common predisposing factors that may predispose someone to both mental disorder and substance-related and addictive disorders, particularly opioid use disorder. So common predisposing factors, common treatments, common barriers to those treatments. Then we want to spend a little time looking at how to recognize and refer, with finally then looking at how faith and community leaders can help with this, and then we'll have some time for some Q&A. So let me share my screen. I think we'll get everything going here. I believe y'all should be able to see the introductory slide.
Yep, we can see it, David. Go ahead.
Great, great. Okay. Let's make sure. There we go. It's advancing. First slide actually has some abbreviations for some terminology that is commonly used when you're looking at mental disorders, opioid use disorder, and other things. So that's kind of a reference slide for you. This first slide is a table. The information is out there. That's one of the things I really want to stress today, is that the information is available through a lot of your government-sponsored websites, the SAMHSA, the Substance Abuse Mental Health Services Administration, the National Institute on Drug Abuse. They have some excellent information out there and available. The Partnership Center is an excellent place to help coordinate that. So what I wanted to do was look at the most commonly occurring mental disorders in the country, then make the bridge to substance use disorders. So you can see the way the chart works. You've got a disorder column on the far left. You've got specific phobias, social anxiety disorder, major depressive disorder, post-traumatic stress disorder, generalized anxiety disorder, panic disorder, persistent depressive disorder, and obsessive compulsive disorder. And so the information was out there. It took me a little while, but I tried to rank order them in terms of the most frequent. And what you can see in that is that there are a number of anxiety disorders, and there are a couple of depressive disorders, and then you've got some trauma disorders there. So so you've got the percentage in that next column to the right. So for example, with major depressive disorder, 6.7% of the population, of the adult population in the United States in the past year has met criteria for major depressive disorder. That translates into over 16 million people in our country. So when you start looking at these numbers, you know, the mental disorders are a significant drain on the life of our country, and it's very important that we recognize that we accept that. Part of the reason it's so important that we do is because everything I know, everything I see is that faith communities and the communities in which faith organizations reside, when everyone's working together, those are actually ideal situations and circumstances to help us meet the need of those who are suffering, those who are struggling. And so it's really important for us to accept the reality of these so that we can also then accept the reality that we may in fact be uniquely suited to be able to address some of the major concerns and hopefully alleviate the suffering of those who presently already have some of the disorders, but also to construct our communities and live with each other in such a way that perhaps we can actually prevent some of these. The current data is over the course of a lifetime, at any point in time over the course of a lifetime, about 52% of the adult population in the United States at some point will meet diagnostic criteria for one of the mental disorders of some type. So the numbers are there. We won't go through every single one of these. I do want to look down below at the substance use disorder category and recognize that any substance use disorder in the past year of almost 11% of the adult population in the United States meets criteria for a substance use disorder. That translates into over 20 million people. Of those with opioid use disorder, the estimates are slightly over 2.1 million people, right? So over the course of a lifetime, about a third of our adult population at some point will meet criteria for some substance-related and addictive disorder, okay? So those are some of the statistics. That far right column, the far right two columns, co-occurring with opioid use disorder. You've got about 2.1 million people who have a co-occurring mental disorder with an opioid use disorder. That percentage column is taken from the article Gross et al. 2013, Gross and colleagues. I was the one that kind of projected that based on the numbers into the number of thousands of people that represent. So the percentages are from that study. I projected those to the population in thousands. So I wanted you to be aware that's not a nationally representative sample there. Okay. So here's another table where you'll hear the word co-occurring used a couple of different ways. Co-occurring can be a mental disorder of some type other than substance-related and addictive disorder. So that's one way you'll see co-occurring disorder used. Another way you'll see co-occurring disorder used is a co-occurring substance use disorder. In other words, one substance use disorder with another one along with it. So the second table, when you look at, for example, marijuana use disorder, you'll see the next column, alcohol use disorder. So what that's saying is that those with marijuana use disorder, 38.7% of those with marijuana use disorder will also have alcohol use disorder. Going down a little, cocaine use disorder, 60% almost of those with cocaine use disorder will also have alcohol use disorder. And then prescription opioid use disorder, about a little over 35% will have alcohol use disorder along with that. So that's another source of information for you, just to get a flyby view of some of the numbers that we're looking at. A very recent study, I mean, this is pretty hot off the press, for co-occurring mental disorders and opioid use disorder. Range from a high of 26.4% for alcohol use disorder to 10.6% for methamphetamine. All right, and so some of that has to do with more people drink than use methamphetamine, that kind of thing. And opioid use disorder, going along with the methamphetamine, you're talking about opioids, which are central nervous system depressants, with methamphetamine, which are central nervous system stimulants, and so those things compete and often aren't taken together. So that's why some of the number is a little bit lower for the methamphetamine. Opioid use disorder and any mental illness, that AMI is any mental illness, was 64.3%, meaning that those things co-occur. So opioid use disorder and any mental disorder, 64.3% of those with opioid use disorder had a co-occurring mental disorder of some type. Opioid use disorder and severe mental illness, schizophrenia, bipolar disorder, debilitating major depressive episodes, things like that, where impairment, where life is significantly impacted, was 26.9%. Now, importantly, those numbers are important to help us get a sense of the magnitude of what we're looking at. I always try to allow my head to get the numbers, and I try to allow my heart to feel those numbers. We're dealing with a lot of people who are suffering. And so in the midst of that, when you look at the receiving treatment statistics, those with both opioid use disorder and any mental illness, 24.5% receive treatment. Those with opioid use disorder and severe mental illness, close to 30% receive treatment. All right, so the good news is we've got, a fourth to almost a third that are receiving treatment. Now, the bad news, of course, is the other side of that. That means 2/3 to 3/4 aren't getting any treatment. And these are people with both opioid use disorder and some other co-occurring disorder. So the implications for faith and community leaders start becoming more apparent. And so as we go through the rest of the material for today, I want us to be thinking of what are the implications of this for those of us in positions of leadership within our communities, right? Okay, another next slide. From another article, co-occurring mental disorder and opioid use disorder. 47% were diagnosed with a comorbid mood or anxiety disorder. All right, so that's almost half. All right, and some of these numbers may differ a little. It gets down to how they measure and who they're looking at, but basically the numbers start lining up. Those with opioid use disorder to prescribed opioids, when they had comorbidity of a mood or anxiety disorder, that comorbidity was related to them having more severe psychiatric symptoms, worse quality of sleep, and elevated alcohol use. So in the context of addressing the opioid crisis that has reached epidemic proportions in our country, that's part of why it's so important to also consider other mental disorders that co-occur, because they relate to the severity, the impact, and that all gets at the level of treatment and intervention and support that people need, oftentimes long-term. And so we just want to keep those things in mind. Another study, very recent, 47% of individuals with opioid use disorder and co-occurring mild to moderate mental illness didn't receive any behavioral health treatment. Okay, so we're talking about half not getting any, knowing that they had both disorders. 21% of those with co-occurring serious mental illness didn't receive any behavioral health treatment. So among those with opioid use disorder and co-occurring mild to moderate, 16% reported receiving both SUD and mental health treatment. Now, among those with co-occurring severe mental illness, the rate was 32%. Again, that's actually the good news, that a third are getting both substance use disorder and mental health treatment. We'll see as we go through that the best ways of responding, it's really emerging that integrated care for mental disorders and substance use disorders, integrated approaches, it's becoming evident those are rising to the top as being most effective. All right, so those are some of the numbers. That's part of what we're looking at in terms of the scope and the severity of what we're looking at. So I want to turn to some specific disorders. As I was pulling this information together, these are the most commonly occurring disorders with opioid use disorder. So it'll be a little out of order from that first table because that was just looking at the most common mental disorders. Now we want to look at the most common mental disorders that co-occur with opioid use disorder. First one's anxiety disorder. There are several different specific types of anxiety disorders. We won't take time during the actual presentation to go into individual disorders, but certainly if you've got questions about specific disorders, we can address those to some degree anyway at the end. But some of the types are specific phobias, social anxiety disorder, generalized anxiety disorder, panic disorder. But the anxiety disorders as a whole are characterized by excessive fear, anxiety, and behavioral disturbance, particularly avoidance. So avoidant behavior is particularly concerning just because it's inherently reinforcing. It tends to just make things and keep people stuck with that fear and anxiety. So fear, think of fear as the emotional response to real or perceived imminent threat. right? And the key there is real or perceived. You know, if someone perceives a threat, they're going to have a fear response. And, you know, there are ways that we can work with folks to help their perceptions to become more reality-based. But you can see that's kind of where the avoidance comes in as well. If you're avoiding, it's hard to confront the reality. So these things start to go together. Anxiety is the anticipation of future threat. So think of anxiety as being related to looking ahead and anticipating threat. One of the most painful aspects of anxiety disorders, but these panic attacks can also occur with other mental disorders. Panic attack is a particular type of fear response, which is prominent within anxiety disorders, but it can also show up with other disorders. And the panic attacks are just these discrete, intense episodes that are very, very painful to the people experiencing them. And they will have physiological symptoms that will send them to the emergency room, and they'll wonder if they're having a heart attack, if they're going crazy. They can be unpredictable. And these can be just very, very painful experiences. The anxiety disorders differ from one another in the types of objects and situations that induce the fear, the anxiety, the avoidant behavior, and then the way people think about their disorders and the fear and the objects that they fear. It's important to remember that, look, being anxious at times, being depressed at times, those are all part of being human. And so I remind people, anxiety is not the problem. It's when that anxiety becomes disordered. That's when it's a problem. Same thing with depression. It is part of the human condition for us to experience depressed mood and depressed feelings and even say, you know, I'm going through a depression. But it's when that depression gets disordered, that's when it's a problem. And so think in terms of intensity and frequency and impairment and things like that. So with the anxiety disorders, the anxiety that occurs in the context of anxiety disorders, it's different than just transient fear or anxiety. It's certainly often stress-induced, but not always. And it tends to be persistent. So think in terms of a matter of degree and things like that. All right, so how this might relate to someone with opioid use disorder is that imagine someone with an opioid use disorder might be using a substance, the opioid, to reduce the excessive fear and anxiety and even the muscle tension, because they're a central nerve. The opioids are central nervous system depressants, and they slow things down, and they can have a relaxing, physiologically a relaxing and calming effect. Okay, so someone could be using a substance, opioid, to help relieve that. The other possibility is that as someone's substance use progresses, they tend to become increasingly socially isolated. And so it becomes more and more of an individual activity. And so it could be that some of that avoidance could be the opioid use disorder as that escalates and increases and the person socially isolates more, so that as they use more of the opioid, that social avoidance of the anxiety and the social avoidance of the opioid use disorder could be going together, and the use of the opioid and the avoidance that goes along with that could be masking the possibility that maybe there's an anxiety disorder. And so part of today is simply giving you an overview. It's not to train you to be diagnosticians. We're just trying to give you some ideas of some things to look for, some things to consider, and we will kind of talk about some referral issues here in a little bit. All right, so depressive disorders. Couple of primary types of depressive disorders. Remember, depression, everybody has some depressed times. It's when that becomes disordered, that's when we consider them to have the mental illness. Characterized by a presence of a sad, empty, and often irritable mood, particularly in children and adolescents. There are physiological or somatic changes. There are cognitive changes. I would also say there are social changes that occur that significantly impact the individual's capacity to function in their daily life. That's kind of the impairment area that you want to take a look at. Also, a change from previous functioning is something to keep in mind. So part of what differentiates major depressive disorder and persistent depressive disorder are issues of duration, timing, or presumed cause. And that also tends to apply to other disorders as well. All right, so someone with opioid use disorder could be using a substance as an attempt to get euphoric effects, right? So if someone is having depressed mood and the opioids in the brain stimulate the pleasure centers, if someone may be using opioids to kind of boost as an attempt to get euphoric effects or reduce the pain of depression. All right, so that's one thing to consider. Another connection is that people with chronic pain are more likely to have a depressive disorder. That chronic pain is just horrible. A little bit of self-disclosure here. Just 2 days ago, I got word that my aunt, my mother's side of the family, she passed away in her sleep. Thankfully, it was a gentle passing, but she had just had horrible chronic pain for numbers of years. Thankfully, she did not end up with a depressive disorder. That chronic pain can really put a strain on people. And so, of course, those with chronic pain, many are managed effectively, thankfully, with prescription opioids. But those who are managed with prescription opioids, that's also one of the kind of portals of entry for a number of people into opioid addiction. And so we just want to make sure that we keep those connections clear. Another possibility with depressive disorder and the co-occurrence with opioid use disorder is that some of the opioid deaths could in fact be related to intentional suicide attempts, since those with opioid use disorder, chronic pain, and depressive disorders are at higher risk for those. I will need to spend some time checking out, see if we can tease that out a little bit, but it's certainly possible that somebody's probably already done it, quite honestly. But some of the opioid deaths could in fact be intentional suicides that we didn't know because someone had an untreated depressive disorder. All right, so that's another reason that we want to educate ourselves, increase our awareness, equip ourselves to have different responses in our community. All right, another mood disorder, but it's different than major depressive disorder, is bipolar disorder. Bipolar meaning two extremes, right? Two poles. So there's the depression side of things, and people with bipolar disorder very frequently have major depressive episodes that typically occur, right? But it's that manic episode that characterizes bipolar disorder. So there's this distinct period of abnormally and persistently elevated, high, expansive, is really big, everything is huge, or irritable mood. And then also along with that, abnormally and persistently increased activity and energy, right? And so these distinct periods of mood changes, they're present to a significant degree, and they represent a change from usual behavior, okay? So someone with opioid use disorder might be using the opioids to help manage the mood dysfunction, to try to smooth out the intensity of the manic episodes, but also maybe perhaps to try to smooth out when those moods shift, and so that the swing is not quite as extreme. Kind of an interesting finding is that those with bipolar disorder tend to be at higher risk of substance use disorders generally, but not necessarily and specifically opioid use disorder. However, opioid use disorder is one of the substance use disorders, right? So it could be there. Another disorder category another disorder that is related to opioid use disorder and co-occurs with it is post-traumatic stress disorder. That's characterized by exposure to actual or threatened death, serious injury, or sexual violence. With post-traumatic stress disorder, you'll have intrusion symptoms, memories, distressing memories, dreams, flashbacks, things like that. You know, people can be walking along and just have a trigger, and it's like hitting a wall. So there can be some very intense psychological distress and physiological reactions to cues with post-traumatic stress disorder. There can also be persistent avoidance of memories or reminders, negative changes in how people are thinking and how they are feeling. There can be marked changes in arousal with sudden surges of arousal because of hypervigilance and things like that. And these changes have lasted more than a month. That's when post-traumatic stress disorder comes in. So I remind people, post-traumatic stress is not a problem. It's an expected reaction when you've experienced something. It becomes disordered when it hangs around or gets too intense and causes too many problems. All right. So someone with opioid use disorder then could be using a substance to help manage perceptual and mood alterations in post-traumatic stress disorder. That depersonalization, that it's almost like they may describe things as like, it felt like it wasn't me. Derealization is sort of like it felt like it wasn't real, like it was a dream state. All right, so that's kind of what those types of things are getting at. And one of the things to keep in mind is that many withdrawal symptoms from using opioids can mimic the hypervigilance symptoms of post-traumatic stress disorder. So when you think of withdrawal symptoms, think of the primary effect of the substance. The body and the brain especially get used to that substance being present, and new set points can actually occur. Then when the body is without that substance, you'll have the rebound effect. So withdrawal syndromes tend to be the opposite of the direct effect of the drug involved. And so withdrawal from opioids, very unpleasant, and a lot of the symptoms mimic the hypervigilance symptoms of post-traumatic stress disorder. All right, so some common predisposing factors. What are some things that predispose individuals to mental illness and substance use disorders? What are common predisposing factors? So there are three kind of main factors, and then we'll tease these out just a little bit. Common risk factors can contribute to both mental illness and substance use and addiction. Mental illness may contribute to substance use and addiction. Substance use and addiction can contribute to the development of mental illness. So we're going to then tease each of these three out. So common risk factors that can contribute to both mental illness and substance use and addiction. There are genetic and epigenetic vulnerabilities. The epigenetic getting at the environment having a role in how those genetic vulnerabilities are expressed, right? So there are common risk factors involved. Be careful of causality. You know, that I've got these hereditary and biological predispositions. Nothing is 100%. So the nature-nurture controversy, in my mind, that's always kind of been nonsensical. I've always wondered what's the controversy. It's always a both and. So there's nature, the genetic, and the nurture, which is the environmental areas. All right, so those are some common factors there. There's also some common aspects of brain region involvement. So different regions of the brain, different structures in the brain, and different chemical pathways in the brain can all have common risk factors to both mental illnesses and substance use disorders. Stress, environmental influences, stress is huge. That gets back to just personally, how resilient are we as individuals to stress. I think it also points to the need for our communities to look at, what can we do to improve the quality of life for the people that live in our communities and live with us. Another key environmental influence, and for me personally, I've always known that early trauma sets people up for all kinds of different challenges and difficulties. But this whole thing of adverse childhood experiences, ACEs, adverse childhood experiences, the data is just overwhelming. The degree to which childhood experiences, traumatic childhood experiences, which can include pervasive neglect. So it's not just abuse events. It can also be chronic and severe neglect. Those just set people up for trouble. The current statistics are hanging right around those who end up with some type of addictive disorder. You're talking like 85% of the people who end up with some type of addictive disorder will report several adverse childhood experiences. The connection is just irrefutable. And so we really have to take a look at not just how we're treating each other, but how are we treating even the most vulnerable in our communities, our children. And I really think our communities, our faith communities particularly, but also our communities generally, really have to take a look at some of the foundational social structures that have taken some hits in the past several decades. We have to do some real soul searching about what are we going to get behind in terms of how we live with one another in the context of our communities. How well do we encourage healthy family living, healthy community involvement, healthy life, just enjoying life itself, larger aspects of life, right? Just broad understanding of spirituality, and that life is bigger than us, and there are these other purposes that are involved. And so again, you can start to see how our faith communities are uniquely suited to participate in some of those areas. Okay, the second common predisposing factor, mental illness may contribute to substance use and addiction. Self-medication is certainly a possibility. There are changes in the brain when mental illness develops and may increase the vulnerability to substance use disorder, particularly if you continue to enhance rewarding effects of things that are normally pleasurable anyway, and you're using a substance, the brain and the body becomes dependent upon the substance. So then you get rid of the substance, and the body just has a hard time experiencing pleasure again, right? The third common predisposing factor, substance use and addiction can contribute to the development of mental illness. Again, changes in the brain when substance use develops may increase that vulnerability to mental illness such as schizophrenia, anxiety and mood disorders, impulse control disorders. Very interesting concept is that when drug use precedes the first symptoms of mental illness, it may produce changes in brain structure and function that kindle. So think of kindling in a fire, right? When you start a fire, you use kindling. Okay, think of drug use as kindling that can light the fuel of underlying predisposition to mental illness. So integrated treatment, common treatments, integrated treatment for comorbid drug use disorders and mental illness consistently superior compared to treating each disorder separately. That really is confronting what has historically been a bifurcated, a split treatment system. You'd have mental health over here, and you'd have substance use treatment over here, and these two would actually go back and forth and compete with each other. And so the best evidence we have is that integrated treatment, where both types of disorders are treated at the same time, those tend to produce the best outcomes for people. There are a number of cognitive behavioral strategies that work well for both mental illness and substance use disorders, particularly approaches that support motivational and functional recovery. Think point of performance, right? So integrated treatments that get at point of performance, where people's, where the rubber meets the road, where they live life. When it makes a difference there, you tend to get better outcomes. Integrated treatment involves collaboration between clinical providers and faith-based and community organizations. So if we're going to do integrated treatment well, which works best for most, then we also are going to have to work on our collaboration and how well we do that with each other and within our communities. There are also some common treatments regarding medications. We are increasingly, our technology for developing medications is astounding. I really think we're at a kind of on the cusp of a good revolution in brain science when it comes to medications for mental illness, but also for the treatment of substance use disorders. I mean, one example that is not too controversial is think of nicotine replacement therapies. Think of the patch and how that has helped so many people, quit tobacco use disorder. So new medications are developing. There's even research into vaccines for addictive disorders. So, I mean, we have really advanced a lot. There are also some common behavioral therapies, cognitive behavior therapy, dialectical behavior therapy, assertive community treatment. You can see the importance of relationship in integrated treatment. Motivational incentives, integrated group treatment, right? So a number of common treatments for both mental disorders and substance use disorders. Now, common barriers, there are also some common barriers to treatment. Only about 18% of substance use disorder treatment programs and 9% of mental health treatment organizations have the capacity to serve dually diagnosed patients, right? So you can see there's a lot of room for improvement there, a lot of room for growth there. And that, to identify these areas of need, point to the problem, but more importantly, I think they point to where healthy, meaningful involvement can really come in and make a difference. So that's really kind of how I want you to look at this, is that these gaps are, man, what if we show up? And what if we show up well? And what if we show up based on what we know, evidence-based treatment? We're there. It's really a matter of, are we going to do this or not? So there's a lack of broad expertise in both treatment systems. So, this is a long-term problem. We need to think long-term solutions, but we've got to get training in both areas, and that's part of why I value the Partnership Center and these efforts that are going on now to look at mental disorders co-occurring with the opioid use disorder. There's also some lingering bias in some substance use disorder treatment communities regarding use of medication. I know these are controversial areas, and really don't want to pick any fights, but someone who is struggling with depression, you can't buy a SSRI antidepressant, a serotonin selective reuptake inhibitor. There's not a black market for them on the street. They just don't work that way. So someone having depression, for example, that might need medication to help the brain, give the brain what it needs to do its job, that's an important thing to treat. Think of the implications for relapse both directions. Think of the implications for relapse on the substance use disorder if the depression is not treated. But also think of the implications for relapse on the depression if the substance use disorder isn't treated. And so we really are at a place where there are some medications that can be helpful for both. Another barrier is many people who have co-occurring disorders are in the criminal justice system. And thankfully, there really is some effort being made now, very intentional effort being made about reform in those areas. Very, very helpful. Common barriers are practical considerations: funding, childcare, access to treatment, getting people employable, right? And again, think of how faith and community leaders can be involved in this process.
David, this is Ben real quick. Just jumping in real quick to let you know we have about 10 more minutes for presentation, and then that'll give us a little time. We may go a few minutes over, everyone, for our time today, but want to get to some of the questions. Just letting David know we have about 10 more minutes. Just want to emphasize on that previous slide as well that medical assisted treatment in substance abuse, especially for opioid use disorder, is a critical best practice that HHS emphasizes, and want to make sure that we encourage communities across our country, including faith communities, to really see that importance of that strategy and recognize how we can encourage people to participate in programs like that. So thanks, David, and we look forward to the rest of the presentation. Let's keep on going.
Absolutely. Absolutely. All right, and I will hustle through, right? Okay, so another way of looking at this, think in terms of personal characteristics and structural characteristics when it comes to barriers. So there's some personal vulnerabilities, severity of illness, lower motivation, things like that. There are also some personal beliefs that get in the way. So you can actually arrange some of the common barriers in terms of personal characteristics, but also structural characteristics. How available is the service? Are people actually identifying the disorders? And, you know, again, this isn't about equipping you to be diagnosticians or medical practitioners, but even those professionally are having trouble doing disorder identification. So when it comes to recognizing, there are some principles that I think can be pretty helpful, and that's what I want to touch on. Think in terms of the degree of distress that the individual is in, and the degree of impairment that they are experiencing. So those can be a couple of ways to think of, is it possible that someone might have a mental disorder along with the opioid use disorder, or just freestanding mental disorder? Think in terms of distress and impairment. Think also of internalizing, right? So people kind of turn inward on these things, the prominent anxiety, the depressive disorders, the physiological symptoms, and then think externalizing. Is it causing trouble on the inside? Is internalizing. Is it causing trouble on the outside? Is externalizing. And then, so think distress and impairment, internalizing, externalizing, and then think of changes. Is what you're observing represent a change in emotional, psychological, behavioral functioning? I'll even certainly want to put spiritual functioning in there. Think bio, psycho, socio, spiritual functioning. So any changes there. All right, as you're engaging people, be sure to maintain good personal and professional boundaries of your own. You know, you're there as a support. You aren't necessarily there as a treatment professional, right? So you're there to help support that process. Find and get competent help. It's available. Sometimes you got to look for it. I know that there are a number of efforts to try to streamline that process across communities, which again is part of why I value the work that the Partnership Center is doing. Start with somebody's physician. Who's a healthcare provider that's involved in a person's life? And just start there. That's a good place to start. Consider comparison to physical illness. Like if you were hurting this bad physically, what would you do? Well, if you're hurting this bad emotionally and socially and spiritually, what would you do? And oftentimes, it's actually kind of the same plan. I'd call the doctor, I'd go to the emergency room, right? Consider the value of communities and faith organizations developing referral lists across communities. where, you know, effective service is available across a wide range of difficulties. Now, of course, if there's an emergency situation, imminent threat to persons, you know, abuse or neglect, those kinds of things, then certainly go to the ER or call 911. All right. So how can faith leaders and communities help? I really think this starts with the leadership. The leadership has to get a vision for this, and a vision for how their communities and their congregations and can be involved in a meaningful way. I'm a believer in prayer. I've certainly been a recipient of prayer, and I am grateful. But I actually put the leadership up there because it's when the leadership gets it, and then the leadership starts encouraging prayer that way, that's when it goes together, right? Especially with the opioid crisis, but also just, you know, life being such a struggle for those and the families of those who have mental illness. Our faith communities especially need to become places where people can just grieve and grieve the loss and the tragedy. We are dying, and we have a culture that is hurting badly, and so we need to be places where that occurs. I think we got to do some theology thinking and reframing, particularly about the physical body, but especially the brain. You know, my brain is subject to malfunction like the rest of my body. So, you know, it's not in its final state yet. So I look forward to that day when it is, but it's not there yet. And so my brain, like my pancreas or my heart or my liver or whatever, can malfunction, and I need care that way. We've talked about the adverse childhood experiences. Different theological and spiritual perspectives have different views of sin. So one way to conceive of sin is thinking about just distortion from the way that it should be, right? The kind of coming up short of what we're intended to be. I think we need to think through those things. Shame and guilt, shame being about the self, guilt being about, you know, behavior. Think objective, you know, I really did something, therefore guilt is warranted. Subjective, I didn't do something, but I feel guilty. All right. Shame kind of being a similar thing. I'm really not all that I should be or will be, but I'm probably more than I think sometimes. So we can tackle stigma. I think part of that is considering the science of mental illness. It's not like you've got to be scientists, but sure, you can translate the science of brain disease and things like that. Talking openly about mental illness in the context of our faith communities, where healing can take place and shame can get reduced. Providing education, giving good information and making it available. Really important, and this is one of the unique aspects of our faith communities, particularly, I think. It's what a better place to promote resilience. And so resilience at an individual level, but think of how doing these protective factors can actually maybe help prevent, change the statistics on the rates of these disorders. Developing nurturing parenting skills, stable family relationships, caring adults outside the family, things like that. Addressing risk factors. I think one area where we can especially do a better job is, imagine if we just simply went after reducing the number of adverse childhood experiences. I mean, look at how just doing that one thing over the next 20 years, look at how we can make some improvements in our lives. And then addressing concerns holistically, bio, psycho, socio, spiritual. Think holistically about persons. Encouraging treatment. Very important. And then really very important that I know the Partnership Center is very concerned about is practical wraparound care, right? Warm handoffs. One group not necessarily doing everything, but realizing other groups are there that can help and making sure that those transitions are helpful. So think of your faith community as a wellness center and be willing to take the lead in your community. And a perfect example of a resource to help you with that is the Partnership Center's Opioid Epidemic Practical Toolkit. Be willing to form diverse partnerships. There are your references. That's where they came from. Keep the primary websites, the SAMHSA website, the NIDA website in view. The information's there. And Ben, I believe, will host and facilitate questions.
David, I just want to echo something so many of our participants have said. This information is so helpful. It's been really clear. I mean, even some people were saying, let him keep going at the end. He's got so much great information. I can't take notes fast enough. So know, everyone, that the slides are going to be something we're going to try and make available to everyone who participated in the presentation today. We're recording the webinar today, so the recording will be made available. I so appreciate that some of you are asking how we can make this information available to the communities, to our staff, to our leaders. And so that's what we are doing this today. This is why we're hosting this webinar, to increase awareness, for you to have a tool so that you can share with other people. And so, you know, we're excited for you to think through that. So I'm going to take host privileges and go over about 5 minutes and just follow up with David with a few of these questions that we got. I appreciate this question from Nadine. She noted that if we're doing early intervention, if we're helping individuals, especially our youth, identify mental illness earlier, then it may be that we would help address people later in life self-medicating through and then experiencing a substance use disorder, because we can help individuals identify some of those challenges really early on. So any thoughts about that? Any ways in which we can help increase awareness early on and then catch some of these and actually maybe have a reduction in the number of people experiencing substance use disorder later on in life?
Yeah, that really opens up where I believe we have the best opportunity to make a difference in the long run. You know, a number of people, individuals, and organizations may not be geared toward the treatment side of things, but good gracious, on the prevention side of things, encouraging these protective factors at individual, family, school, and community levels is huge. And so the more that we can have a contrast. Here's how you can live life well without the need or the desire to experiment with something to try to make it better. How about let's just help life be good and valuable and meaningful? And see, I think as that difference becomes more apparent, it will be easier to determine who's on a trajectory toward trouble, and can we intervene early? Because that's what the data says. The earlier, when there is, best way is prevent trouble in the first place.
Mm-hmm.
If trouble shows up, then the earlier the intervention, the better it tends to go. Another key factor, particularly with substance use, is the longer you can wait for the initial age of onset, the older someone is, if they ever try something, the less likely it is they'll have troubles with it.
Mm-hmm.
And it's kind of the same with the mental disorders too. If we can just get people through these developmental phases, reduce the stress, the older someone is, the less likely they may be to have these difficulties. Now, it's not a guarantee, right?
Mm-hmm.
But then in the event that they did develop something, you've got a supportive network and community. So very, very important question, Nadine.
Thanks. Yeah, no, I thought it was exceptional. Many people had some questions about the early slides and some of the numbers, and I've made sure that people know in our comments and chat back and forth that you've provided the citations for all the papers you referenced, and many people can kind of take a deep dive into those numbers if they'd like to get more information from those slides. So,
right, and most of that is from the SAMHSA.gov, SAMHSA.gov, and drugabuse.gov, which are the SAMHSA, Substance Abuse Mental Health Services Administration, and the National Institute of Drug Abuse website. So that's where a lot of that information comes from. Honestly, look, is your tax dollars hard at work?
Exactly. No, and we're excited to make sure more people know about those excellent resources.
Right.
David, how would you suggest, screening kind of strategies? You know, are there ways in which, and strategies by which we can increase awareness, make sure that we have some strategies in place for you know, thinking through some of those those factors that may predispose perhaps, or even, you know, just help people know that they're at risk. Is there anything to think about as it relates to increasing awareness of screening strategies?
Well, I'll try to answer the specific question, but I'll get there this way first. You know, as soon as you asked that question, Ben, the first thing that popped into my head was there has to be an established relationship.
That's a great point.
The best way to do screening is be in a meaningful relationship with someone so that you can tell when there's a difference that shows up.
Mm-hmm.
I mean, right? And so in the context of a loving, caring relationship, you know, that screening then, okay, are there changes? It goes back to those several principles that I mentioned. You know, has there been a change in someone's behavior? How is someone more distressed than they used to be about the symptoms that they're experiencing? Is there some level of impairment that is now occurring? So it really requires just being watchful and being mindful, right?
Mm-hmm.
And so that's really kind of the first place to start. Formal screening really is something done by
practitioner.
More professional, practitioners. So at our level, which is where really it works best, is just that awareness, and then being supportive of people, getting them the help, and transitioning into, you know, it goes back to that warm handoff you talk about, the wraparound care, right?
Yep. That's a great point. And actually, Dave, I couldn't ask for a better transition. Can you bring up that last slide that we have in the presentation and share your screen? It might be easier for you to do it than for me. You know, one of the things we wanted to make sure that all of you think about and consider is that even with your awareness of how opioid use disorder and substance use disorder may kind of overlap, it's really important to think about signs and symptoms. You know, and so the opportunity you have is to be aware of signs and symptoms, not necessarily screening, but just being aware of some of the things we have up on the screen right now, observable categories of different strategies, and then examples of what those look like. This comes from the American Psychiatric Association's Faith Toolkit, a really exceptional resource, and it's a piece of their research or report where you can have these signs and symptoms. You can be thinking about them. Note here that they're completely separate from any diagnosis or criteria that you might want to think through. So it's not about you screening the information. It's about being aware of these signs and symptoms. And if someone experiences any of these, it may be something you want to encourage the individual to visit with a professional who may be able to help them address some of these concerns. And so again, it's the opportunity that we have with faith and community leaders to be aware of signs and symptoms, some of the things that we talked about today, and then make sure that individual gets the most effective referral that they can have to a support system. And so we want to make sure that you are thinking about, have these signs and symptoms in mind. We're going to be sharing this on our social media pages, both on Facebook and Twitter, as a resource that is available that you can have, you know, when you're thinking about individuals in need in the community. Instead of necessarily thinking about formal screening, it may be helpful to just have these signs and symptoms in mind. And if someone is experiencing any of them, think about how you could refer them to a mental health professional for a formal diagnostic. So our social, oh, David, go ahead.
Yeah, I want to second what you're saying. I looked at that resource, that psychiatry.org /faith resource that this slide was based upon. That really is an excellent resource. So people checking that out would be, you know, they'd be well served to do that.
Well, David, thank you so much. You're David to me, you're Dr. Jenkins professionally, but it has been wonderful to have you present here. I want to thank everybody so much for participating. We did it through the chat feature, but I also want to honor and appreciate so many individuals who participated who are maybe struggling or have a loved one struggling with a mental health or substance use disorder, as well as individuals who have loved ones in that circumstance. Thanks so much for joining today and hearing a little bit more about these challenges and hearing from such a great presentation where we can increase our awareness of some of these strategies. Our social media, so some of you have asked since I mentioned that, is Partners for Good, Partners, F-O-R, Good, on Twitter, and then the HHS Partnership Center on Facebook. You can see us there. You'll see more information about our upcoming webinars. I want to encourage you, if you haven't already, to sign up for our next webinar that will be happening in May. And so that's another place where you can join us again, learn a little bit more about some of these mental health disorders. We'll be focusing on anxiety disorders with someone who has an expertise in that space, Dr. Tim Sizemore. And so we're going to be looking forward to continuing this dialogue with all of you as we move forward. Dr. Jenkins, any final remarks?
Just thank everyone for attending. I really appreciate the interest and motivation, and just my prayer is that it's helpful.
It certainly was to us, and I'm sure it was. Many people commented how they appreciate it. So thank you, everyone, for joining us today. We're so pleased that this webinar has been supported, and we look forward to seeing you on future webinars as we move forward throughout the year. Thanks so much, and have a great day.